Today, I wanted to talk with you about postpartum depression. In 2015, there were 11 published studies using fMRI to look at brain structural and function changes that occur with postpartum depression. Since that time, in the past 4 or 5 years, there's over 20 similar publications now looking at how does the brain change during normal pregnancy, and also how does the brain change during postpartum depression. Since a lot of this data is newer, I'm really excited to provide a summary of some of the information, and a lot of this has come out long since I finished medical school. I began having an interest in women's mental health with a single individual. A resident approached me, and I had worked with her very closely as a medical student. She said that she had had a baby a few months prior and was struggling with postpartum depression. I asked her to come meet with me so that we can talk and I could figure out how to help her, including referrals, whatever she would need. When we met, she said that she had at least the last couple months where she was having crying episodes every day, was struggling with feeling like she was in a fog, poor cognition, feeling tired, feeling overwhelmed, feeling trapped, at times being very anxious, having perseverative thoughts about her worth and her value as a mother. And one of the most concerning symptoms for her was that when she held her son, she didn't feel any kind of joy or connection to him. It was as if it was a stranger's baby. Over time, those thoughts began to shift and to morph until she began to believe that maybe she was a burden to her family and that maybe her baby would be better off if he had someone else for his mother. One night, in the middle of the night, as she was breastfeeding and struggling for over the 100th time, she heard a voice whisper out in the darkness, and it said to harm her baby. The most concerning thing to her was that the voice made sense to her. She immediately took her child and found her mother-in-law who was staying with them and asked her to please keep the baby safe. It wasn't until years later that the resident, who then went on to become an attending physician at another institution, told me that the next day she had taken out all of the pills that were around the house and things that she had collected over time, having had thoughts about suicide, and actually put them into her hand with the intention to end her life. I have no idea why she contacted me rather than committing suicide that day, but I'm grateful. I referred her to a colleague, somebody that had worked with postpartum depression in the past, and also kept very, very close tabs on her myself, checking in and providing as much support as I could as she clawed her way out of depression. To this day, every year on her son's birthday, she sends me flowers and a card, and she thanks me for helping her son still have his mother, who incidentally now adores him. After this experience, I went on to build a women's mental health clinic at the Behavioral Health Institute so that I could work with these patients similar to her and be able to teach the residents about women's mental health issues. Additionally, a couple of years later, I also built a physician healing clinic where I would be able to treat residents and other fellows who have issues with depression, burnout, anxiety in a safe space. And this has been something that I've been really passionate about over the years. Currently, I'm treating over 85 residents and fellows right now. The prevalence of postpartum depression is about 1 in 7 women who've had a baby. 50% of mothers who have postpartum depression will never seek care. And this number is even higher and more concerning in women of color, where up to 33% of them will experience postpartum depression, and yet because of fear of being found unfit or unable to take care of their child, they will end up not getting help from anyone at all. Suicide is the most common cause of mortality in postpartum women. However, suicide during the pregnancy is also a risk and a concern, especially when you're talking about postpartum depression. A few years ago, I had a patient who was admitted to the inpatient psychiatric hospital after a suicide attempt in her 28th week of pregnancy. The patient had no prior history of depression or suicidal thoughts before the pregnancy and had functioned as a high school guidance counselor, had a family who was very supportive, and had loved her job. The patient at the time of admission continued to have very distorted thoughts, thinking that her life and her baby's life were of no value, thinking that it would be better if they went to heaven, and had very, very profound feelings of hopelessness, shame, loss of worth. Over the course of hospitalization, she improved to a degree, but we continued to have very significant concerns about the degree of distorted thoughts that were there. To her, all of the thoughts made sense. All of the thoughts related to suicide continued to make sense to her because her brain was not able to see that these were distorted. My colleague and I met with her family and implored them to please encourage her to stay longer as her involuntary hold was expiring. The family had very rational, logical arguments. They said that this patient had wanted the baby. It had been a planned pregnancy. She had a very strong faith. Her husband was going to be taking time off graduate school to monitor her in the home, and that they felt that being in the home would be what would make her happiest. My colleague and I explained to them that these were normal and reasonable and rational arguments for people whose brains were functioning in that way. But this patient, even though she had these protective factors, was not able to look at those factors, and they made no sense to her because her brain was so ill and so distorted. We were fearful because her intent to end her life continued to be present. And while her family believed that they would be able to monitor adequately, we had a lot of concerns. Her family ended up taking her home from the hospital despite the recommendations, and we were unable to keep her there any longer against her will. Within 2 weeks, she had walked onto the freeway in the middle of the night. Both she and the child were killed. Suicide during pregnancy, suicide in the postpartum period are very serious, and obviously postpartum depression is something that needs to be screened for and watched for very closely. I want to talk a little bit about normal brain changes that occur during pregnancy. So during pregnancy, there is huge increases in estrogen, up to 100 times normal levels. In addition to that, there are progesterone increases 10 times the normal. And then in the third trimester, there are increases in glucocorticoids up to 5 times. What this equates to in the brain is kind of like the brain that you think of in adolescence, where there's giant surges of hormones, and during that period of time, there's massive brain changes occurring, primarily regarding pruning and looking at diminishing total number of cells with the overall goal of getting more productive synapses. So just like in adolescence, huge surges in hormones, and as a result, there's gene transcription that is regulated, there's changes intracellularly, and the ultimate result is a widespread volume loss of gray matter. And it seems like that would be a bad thing, but in actuality, you end up with increased plasticity, refined connection, and the brain being able to function on a higher order. And so while these changes sound like they would not be advantageous, they actually are something that developmentally appear to be very protective. Before we go into changes that happen during the postpartum period, I wanted to just briefly review the parts of the brain that we're going to be talking about next that we see changes in, both in normal pregnancy delivery and also in postpartum depression. So I wanted to just review the structures that have had the most attention within research in the last 3 to 5 years for a quick review. So dorsolateral prefrontal cortex. This is a lateral frontal cortex structure, and it's involved with executive functioning, planning, coordination of action, being able to use working memory. This is the part of the brain that helps us make plans. Next, I wanted to look at the amygdala. And the amygdala is pretty much the seat of emotions, the generation of emotions, and being able to evaluate external situations and determine what emotion is the most reasonable. So information comes in from the cortex to the amygdala with information saying, this is a dangerous situation, this is a fearful situation, and the amygdala then will generate the emotions of fear that then go throughout the cortex and lead to actions. Normally, this is a very useful process. The amygdala produces emotions, and those emotions are just information. What becomes problematic is when those emotions are then led to distress. And so the amygdala, when unchecked, can very much lead to a distress state throughout the entire brain, a condition that oftentimes I refer to as a person with their brain on fire, with their brain activated and distressed in an emotional state that is not being regulated by other parts of the cortex that are supposed to be doing that. And so if we look at those other parts of the cortex that are supposed to help regulate the amygdala, help calm a person, help a person to be able to identify that they're in distress and reduce those emotions, include the anterior cingulate. The anterior cingulate cortex is part of the medial frontal cortex, and it is very, very important for not only regulating the amygdala and helping to calm that, helping to say, what is the data? What do we actually know about this situation? And is this emotional response out of proportion? Is this not that big of a deal? Is this not actually that salient? And the anterior cingulate, part of its job is to regulate and diminish the amygdala's response in given situations where the amygdala's response is over and not needed. In addition to that, the anterior cingulate is very, very important for emotional bonding, for being able to form empathy, to form a maternal fetal connection, to be able to bond with other people. A lot of very cool data about theory of mind, one's ability to understand how other people think and how other people might be processing. These are all important parts of a mother and a child being able to bond, to form healthy attachment, and for there to be empathy in existence. So anterior cingulate, useful to turn down the amygdala response and to be able to form an attachment with her child. Next section I wanted to look at is the medial prefrontal cortex, specifically the ventromedial prefrontal cortex. This area of the frontal lobe is very important in modulating the amygdala in a different way. This modulation very much looks at what are my values, what is important to me. I am currently feeling dysregulated. I'm currently feeling strong emotions. How do I actually feel about that? What do I actually need in these moments right now? And oftentimes the ventromedial prefrontal cortex allows a person to be able to identify how their feelings and values do not align with the emotions they feel in that moment, and in doing so are able to turn down the amygdala response. So this is something that's used for insight and for introspection. This is the part of the brain that is active during meditation. Lastly, I wanted to look at the striatum. Now, obviously, we think of basal ganglia structures having to do with motor function and with coordination of movement, but we also know that the striatum has to do with reward pathways. The nucleus accumbens makes up the seeking system, looking for things that are externally rewarding. And these dopaminergic pathways are very, very essential in helping to reinforce behaviors and being able to get reward, leading to behaviors being done repetitively. So in terms of feeling success, feeling productive, feeling proud of your work, all of these are things that are reinforced by the striatum. So to pull all of this together, how do these systems link together? Here's an example from daily physician life. Let's assume I get a page right now and it's from my colleague and it says, hey, guess what? Next weekend, I'm not actually going to be able to cover for your vacation. I'm sorry, I know this is late notice, but I got something else that came up. Upon reading that information, the information I've just read goes into the cortex, to the amygdala, and my response initially, when getting a page that says I don't get to take my vacation anymore with 4 days notice, looks kind of like this. And the response going through my brain is, this is a big deal. This is disappointing. I'm angry. I'm frustrated. I'm disappointed. Prior experiences with this individual potentially also canceling, could be adding to that. And the amygdala is setting a signal throughout the entire cortex. I then have one of two options in my brain. Number one, the amygdala says, this is a big deal. I can use the anterior cingulate and calm and say, actually, this isn't that big of a deal. Let's look at the information. Let's figure this out. You were just going to stay home and chase your kid around in the backyard, and you were looking forward to that, but technically that can move to another weekend if you absolutely had to. This is less than a huge deal. We can come up with a plan, but let's just calm first. The ventromedial prefrontal cortex is able to say, what are my values? Right now I'm feeling upset at this individual. Right now I'm wanting to send them a really mean text back. Right now I'm wanting to be very reactive and angry. But how am I going to feel about this later? And how do I really feel about this? Between those two structures, you can see the amygdala be able to calm. Once the amygdala is calm and my brain now belongs to me and is not a toddler brain that's being really mad about a page that I'm upset about, I can then begin to engage other structures, and that would be dorsolateral prefrontal cortex. And I can be able to come up with plans. I can page a bunch of my colleagues and say, hey, can anybody cover this weekend for me? I can be able to identify what I want and what my goals are, and I can be able to be rewarded when those goals are reached. Interestingly, I also have a different path I could follow. I can have the amygdala, my brain is reactive, my emotions are through the roof, and instead of engaging these systems and calming it, I can immediately just engage the dorsolateral prefrontal cortex. And what happens in that situation is I have a distressed brain, but I don't know it. I'm not calming it. And instead, I'm just focusing on solutions, but those solutions are not in alignment with my values or my core, and they're being done out of distress. And so instead, in that situation, I have my amygdala using my brain like a puppet. And basically, the amygdala is distressed. There is distress flooding through the whole brain, and the dorsolateral prefrontal cortex is now using that data to come up with solutions. And so instead, the text I send to my colleagues is one talking about how this other person flaked out and is not going to cover my vacation, and how I'm really mad about it, and will somebody else please help out with this instead? And I may send a text back to the colleague that didn't be willing to do the vacation and say, I'm super disappointed. I don't know why you keep doing this. And I end up with using the part of my brain that's supposed to come up with plans being distressed and not even realizing that I'm distressed. And I think as physicians, this is something that can happen if we are not aware of emotional response. And this is just a normal thing that can happen in a person's day. This is an example of how these structures are interrelated and how that regulation of emotions is a fine-tuned process, that there's a lot of different feedback between different areas of the brain. Okay, so normal brain changes that happen during postpartum depression. Normal brain changes that happen in the postpartum to every human being who's had a baby. So we just had gray matter volume loss, and now there's actually some changes that will happen in the 2 weeks to 4 months postpartum, where you get to actually see that being undone in a way and also improved upon. These shifts that are going to occur in volume are going to happen 2 weeks to 4 months later. And a lot of these shifts can actually be longer lasting than that. So looking at the changes that happen within the brain after having a baby include hypothalamus, where you can have increased motivation, increased energy, increased drive to engage and interact with the infant. You can see the striatum increase in volume so that there is more rewards when the mother pays attention to the baby's cry, when the mother is able to do things on their own and be able to function and have autonomy when taking care of the child, a sense of productivity, a sense of success, and that occurs largely because of an increased volume in the striatum. Within the amygdala, there is increased volume, and interestingly, oftentimes this is not led to increased amygdala with heightened fear, but just the amygdala's response to the infant cue. So that if the infant starts crying, the mother pays attention to it better, recognizes there's something that's important happening, and directs the brain toward it. Medial prefrontal cortex, you get an increase in gray matter volume so that now you're able to modulate the amygdala much, much better. And the anterior cingulate being able to have empathy, attachment, bonding, and also calm the amygdala. All of these areas are going to increase in volume over the months that follow. Interestingly, in the weeks that follow after having a baby, there will be widespread drops in estrogen and in progesterone levels. And because of that, you can see dramatic mood changes that happen and can include a lot of the symptoms that you might see in postpartum depression, like crying episodes, feeling overwhelmed, feeling fearful. However, those changes really are only supposed to last days to weeks, no longer than that. And that can be normal in up to 80% of women. So first couple weeks, a few days to couple weeks, you should expect to see changes in mood that's directly related to drops in the hormone levels. However, in the period of time from 2 weeks to 4 months, you're actually seeing a better ability in a mother to calm, to bond, to connect with the child, and being rewarded for doing those things. And this is the beautiful, normal process that's happening in the brain after a person has a child. Conversely, these are the changes that you see in postpartum depression. You see reduced brain volume. So you don't get this reciprocal increase in the volume like you see normally. And you have a reduced brain volume in the anterior cingulate. What is that doing? That's helping you to calm and also helping you to be able to bond with the baby. The superior temporal gyrus, the parahippocampal gyrus, has reduced volume, which is present in psychosis and the inability to detect that there's something wrong. You can see reduced activity in the amygdala. And you would think, well, that means that they're going to be less reactive. Well, actually, it's just the part of the amygdala that is picking up on infant distress and citing that it's important. The part of the amygdala, the response that is saying that there's predictable threat, that there is risk, that there's something to be afraid of, is actually pathologically increased. So the amygdala's response to your infant in distress is less, to the point it's pathologically less, and the amygdala's response to anything around you that could create fear or make a person be fearful is much, much higher, leading to a person jumping at small sounds, being fearful that people are going to break into the home, fearful that the child is going to die, fearful that something terrible is going to happen, and oftentimes just feeling trapped in their own body and their own brain and not knowing what is going to be safe. As a result of this heightened fear, you have people that oftentimes in postpartum depression will just want to pack a bag and leave, but have no real clear indication of why they would do that or where they would even want to go. The dorsolateral prefrontal cortex has reduced activity, so poor concentration, brain in a fog, reduced executive function. There's also reduced connectivity between some of these circuits, these calming circuits, so that medial prefrontal cortex in the amygdala, diminished ability to have insight that there's something actually wrong, diminished ability to see these thoughts don't make any sense, they're not in line with my values, diminished ability for connection between prefrontal cortex, anterior cingulate, and the amygdala, trying to be able to calm. And then finally, difficulty recognizing that there's even distorted thoughts there because of diminished connectivity between the part of the brain that can do planning and reasoning and logic. And so the thoughts that are there are distorted, they make no sense, and the person has no ability to detect that. Finally, there's diminished neurotransmission. So throughout the entire striatum, there's poor dopamine binding. So there's diminished reward. You're able to give the baby a bath for the first time all by yourself. In a normal brain, the mother has a feeling of success, and I've done a great job, this was hard. And in a person with postpartum depression, they feel nothing. There's no sense of accomplishment there. There's no reward when interacting with the infant, no reward in responding appropriately. The anterior cingulate, that's supposed to be able to calm the amygdala, that's supposed to help with attachment, help with bonding, has poor binding of 5-HT1A, serotonin 1A, which is the number one serotonin receptor associated with being able to diminish anxiety, to find peace, to find calm. So the variability for the neurotransmitter that's going to provide calming is just not there, down 20%. This is something that actually will improve and reverse with SSRIs, and also is found to improve and reverse at least somewhat with breastfeeding, which is why breastfeeding is something that is very protective when it comes to reducing some of the symptoms of postpartum depression. Finally, diminished neurotransmission in the prefrontal cortex with increased monoamine oxidase activity. So you end up with breakdown of serotonin, breakdown of neurotransmission that you need for management of depression. These are a lot of different changes that are happening, none of them good. And this is a brain that is not functioning normally. This person may have no understanding that what's happening is not normal. They may have no understanding that their brain is not working well. And telling a person that it will pass or it will get better in time or they just need to think positive thoughts is not going to undo diminished brain volume activity, connectivity, or neurotransmission. This is a biologic illness where the brain is not functioning the way it's supposed to be functioning. What this ends up looking like is an inability to calm, feeling fearful, feeling overwhelmed, feeling trapped, not being able to sleep, being perseverative, and being more and more trapped in a person's head. At the same time, you have an infant that you're not bonded with, that you struggle to feel a connection to, and that leads to profound shame. All of these thoughts, all of these symptoms over the course of time only magnify and get worse. And in many patients, the thought of suicide is not one that you would say this person is struggling and therefore it makes sense that they would think about suicide, but it's more along the lines of this is just a more advanced symptom. And so this person already has a brain that is not functioning well. Suicidality is a more end stage symptom. And when this shows up, this is a brain that is going to be less likely to be able to prevent it, to be able to protect against it, because it's already in a distressed state. Looking at DSM-5, the Diagnostic and Statistical Manual for Psychiatry, depression versus postpartum depression. The DSM-5 has a peripartum onset specifier. So basically it says anytime during pregnancy up to 4 weeks following delivery, which for most people that treat postpartum depression and the other specialties that also encounter this as far as pediatrics, OB/GYN, know that this is something that lasts much longer than 4 weeks after. But that's the amount of time that DSM at least has in it. But the thoughts with postpartum depression are that the symptoms are similar to depression, but have their own flavor. And a lot of that really has to do with that inability to calm the heightened fear response that is unique to postpartum depression that can be present in an anxious depression, but not all depression looks that way. In postpartum depression, this then looks like the inability to sleep when the baby is sleeping, as we talked about, lack of ability to bond with the baby, negative thoughts, distortions, guilt, shame. Some others will have substantial somatic symptoms where they've got headaches, chest pain, fatigue, and the inability to be able to manage these symptoms even with talking with their outpatient physicians about them. The symptoms only are going to get better, honestly, with the depression getting better. Forgetfulness, living in fog, additionally struggling to be able to get the energy and the motivation to be able to provide care for themselves, in addition to heightened fear state. And then finally, the intrusive thoughts, the fear of harming themselves or the baby. These are the types of symptoms that are going to show up in more severe illness. They're not one of the first symptoms that show up with postpartum depression generally, and generally indicate that the brain is very, very distressed, very, very ill. And at the time that suicidal thoughts show up, oftentimes the person's ability to understand that these thoughts do not make sense is impaired because of all of these other functions. New article came out in November of 2020 looking at postpartum depressive symptoms, and the DSM, understanding that this is something that is from pregnancy through 4 weeks after delivery, this challenges that and says actually there are 25% of women, all women, a quarter of everybody that has a baby has elevated depression symptoms at some point for 3 years after birth. Additionally, 5% had persistently high levels of depression for 3 years after, and this is untreated depression. Half of the patients had symptoms that developed during the pregnancy. So the American Academy of Pediatrics very much is looking at 6 months postpartum. Let's continue to monitor, let's continue to do evaluation, and the screening that's used for it has to do with the Edinburgh Postnatal Depression Scale. This is based off of a 10-item scale that included suicidality, but there seems to be pretty good data to support the briefer 5-item scale to help screen for postpartum depression. And recognizably, there are a lot of issues when it comes to providers having time to address all of the things that they need to do in the visit, in addition to being able to address postpartum depression. And I think this is another area for improvement and for study, because I definitely think that these are symptoms that are important to track and to monitor, because they can lead to a person being in a depressed state, not just for 4 weeks or 4 months, but can persist for years if untreated and unrecognized. Postpartum blues, postpartum depression. One thing that happens commonly is that a person with postpartum depression says, this is just postpartum blues. Postpartum blues, as we discussed before, plummeting estrogen levels, plummeting hormone levels, widespread changes in mood that last days after the baby's born until weeks. If it's a month or 2 months after the baby's born, it's no longer postpartum blues. Postpartum blues occurs because of a short-term change in hormone levels. Postpartum depression occurs because of widespread changes in the brain and reduced functioning in multiple areas of the brain. And this is something that will last weeks to months. I think that if I had only a few take-home points, that's one of the most important that I can convey. In addition to that, postpartum depression can have thoughts of suicide. Generally, postpartum blues, not going to have any thoughts about suicide. So tearfulness, irritability, not having thoughts about suicide. Postpartum blues is limited, and postpartum depression can lead to worsening depression, loss of functionality, and potentially even suicide. We talked a little bit about some of the protective factors when reviewing that case of the patient that had completed suicide during the pregnancy. And while I think that risk factors and protective factors are important to know about, you also have to be able to consider the state of the person when you're talking with them and the state of their understanding and their insight into the illness. And if the person lacks insight into the illness, making sure that that family is monitoring and is on board is important, in addition to making sure the family can help secure care. A history of depression is probably one of the greatest risk factors for postpartum depression. As mentioned on one of the earlier slides, a history of postpartum depression, especially if untreated, increases the risk for postpartum depression in a subsequent pregnancy. Something interesting I just want to highlight in this slide has to do with breastfeeding. As mentioned before, breastfeeding is something that is able to support and reduce some of the symptoms of postpartum depression as relate to the lack of serotonin binding in the anterior cingulate. So breastfeeding is important. However, patients that have depression and anxiety oftentimes will struggle to be able to breastfeed and to breastfeed successfully. Because of that, in my opinion, while it's very important to encourage breastfeeding, if a patient is depressed and anxious and struggling and having really significant distortions about their worth and value, and breastfeeding is at the center of all of that, if after a few weeks postpartum they're still struggling to breastfeed and they decide that they want to supplement with formula, supporting that decision in a patient with severe depression or anxiety is going to be protective for this person getting better. And I really do want to make sure that there is some degree of grace for these patients in that. The risks associated with untreated depression are not only to the mother, but also to the child, including poor ability to bond with the child, poor attachment. It ultimately can lead to child abuse or child neglect in mothers that have got severe depression with a lack of functionality. There can be family and marital discord. There can be more ER visits, and the episodes can be prolonged over time, and it can affect other children in the home as well. I want to just briefly talk about treatment because there are good treatment options. SSRIs have very, very good data for management of postpartum depression. Top two options are sertraline and escitalopram, considered first line primarily because of minimal amounts being detected in the breast milk. However, I've had cases of pregnant patients who had serious postpartum depression. I've had them on sertraline. It's been 2 months. They're still struggling with connecting with the infant, still struggling with getting basic things done around the home. And in those cases, I've called Dr. Elaine Hart from OBGYN and I've said, hey, I've got this person on Zoloft. They're not getting better. And it's been really great to have that support and that additional information. And essentially she said, what were they on before? And I said, they were on duloxetine and bupropion. And she's like, put them back on those. And I was like, but what about lactation and safety with the baby? And ultimately, there's minimal data that's going to show that any of these medicines are causing problems in the infant. Minimal amount is even being transmitted to the breast milk. And if you have a mother at 2 months that's struggling to attach and is not caring for basic needs around the house and struggling to even be able to get energy and motivation to do things, it's time to use the medicines that were effective before. And I've really appreciated that support from Dr. Hart because it's something that really changed my perspective in treating these patients. For mothers that are non-lactating, there's a lot of options. The biggest thing that I focus on at the beginning are, let me see, sleep and anxiety. The SSRI is going to take 4 to 6 weeks before I see any improvement. So I can get sleep and anxiety better within days. And that sleep can be a problem if they're the only person at home taking care of the infant at night. And so you have to see what kind of support do I have at night for sleep that's going to be able to help this person to be able to do childcare at night so that I can get them good restful sleep with medication. And if that support is not there, then looking at things like melatonin might be a better option. But for those patients that have support at home, I'm going to look at Ambien, Trazodone, something that's going to really make sure that the person can fall asleep and stay asleep. And anxiety in general, I'll avoid use of benzodiazepines for a lot of reasons. SSRI is first line, but then you can augment with a medication that's going to enhance GABA. Oxcarbazepine is a good choice. Gabapentin is a good choice. And I think that for mothers that are non-lactating, these are great options because I'm not concerned about these passing to the breast milk and affecting the baby. They will end up managing the anxiety very, very quickly in a way that doesn't have the abuse potential that the benzodiazepines do. In 2019, the first FDA-approved treatment for postpartum depression came out, brexanolone. The data for it is pretty impressive, looking at greater than 90% remission. And this medication functions in a totally different way than any of the treatments that we have within psychiatry. This is a neurosteroid metabolite of progesterone. And if you look at the fact that all of these brain structures have changed in response to these hormones, it makes sense that this is at least part of that mechanism. Additionally, this is something that's going to allosterically modulate GABA A. GABA A, that's for calming. And so unique to postpartum depression, that heightened state of fear, the ability to want to escape and feeling trapped, all of those symptoms are symptoms that will get much better with this treatment in addition to the rest of the symptoms of depression. This is a medication that has to be used in a medical setting and has to be infused over 60 hours. The cost is great. However, my thought process is that if an SSRI has failed, and this is a person where you're looking at loss of functionality, risk for suicide, more severe depression, brexanolone is oftentimes cheaper than an inpatient prolonged psychiatric hospitalization and less expensive than electroconvulsive therapy. So when looking at postpartum depression, mild symptoms where the person is still able to do self-care, but they're struggling with bonding with the baby, crying episodes, feeling anxious, overwhelmed, but they're able to do things around the house. They're able to do basic care for themselves and the child. Psychotherapy is a very good option in addition to making sure that they have support and leave off of work. For those that have more moderate illness, such as those that are struggling with ADL, struggling with providing care for the child, and have more profound issues with bonding with the child, shame and guilt, an SSRI plus therapy is your best course and treatment. In addition to that, there are programs like our outpatient partial hospital program where patients with postpartum depression can do more intensive daily therapy in addition to medication management. Finally, for patients that have suicidality, especially with plan or with attempt, those with homicidal ideation or thoughts about harming the baby that they do not feel that they're able to control, and symptoms of catatonia where the patient gradually begins to stop eating, to stop moving, and to stop caring for themselves. In those cases, inpatient hospitalization, electroconvulsive therapy, and brexanolone are really your best options to be considering. Red flags, as mentioned, suicide, symptoms of mania, symptoms of psychosis, catatonia, those are very, very good reasons for referral. Patients that have eating disorders and substance use disorder, also very good for referral to psychiatry. As far as frontiers, there are a number of studies that are being done to better understand the mechanics of postpartum depression, including DNA submission through a phone app. There is Mass General is doing a study looking at a new screening tool, and our OBGYN department at Loma Linda is doing currently a randomized controlled trial of smartphone delivered education in the 3rd trimester. The preliminary results are pretty encouraging as far as showing an improvement in postpartum visit follow-up in the intervention group that paired with screening, I think could go a really long way. If I get 5 take-home points, postpartum depression affects 1 in 7 women. It is structural and functional brain changes. This is a brain that is not functioning the way it is intended to work. If it's been 4 weeks since delivery, this is not postpartum blues, this is postpartum depression. 50% don't seek care. If the patient is in the office for another reason, if the patient is bringing a child in for a visit, screening for 6 months is very important, because patients with postpartum depression often don't know that the symptoms are severe as they are, or because of healthcare disparities, will not seek care because of fear of being found to be unfit. And then finally, there are excellent treatment options. SSRIs are very safe in breastfeeding, and treating is much better than waiting in patients, especially as the condition progresses. I've included some postpartum depression resources here for review that I felt are good to not only give to patients, but also for us to go online and to see what things exist online in that community for mothers that are struggling with postpartum depression, really looking at how do you diminish shame and how do you diminish the stigma associated with mental illness. Finally, I did a grand rounds for the Department of OBGYN about 3 years ago. And I talked with them about my own experience with postpartum depression. And I felt that this was something that was able to tell a story that's a little bit different than just telling about patients' experiences. This is something that's difficult. And yet at the same time, I personally believe that if physicians are willing to talk about burnout, depression, anxiety, their own struggles, we will create an environment where we can be transparent, where we can be connected, and we can be honest. So for that reason, I wanted to share with you in the last couple minutes that I have my own story. It's something I've written down to be able to read. It's a little easier for me. My mother always said that when I had a child, I would know true love in a way I could never conceptualize. It'd been a very long path to getting the child, and when he finally came to us in May 2016, I felt nothing. Actually, I felt worse than nothing. For the first couple months, all I can remember is darkness. I felt alone to my core. I felt like I was drifting, disconnected, and lost. In my mind, my life was over. It was forfeit. The child had not been a beaming ray of sunshine, filling me with hope and life and love. When I looked at him, I felt nothing. The guilt of this overwhelmed me. I wrestled with options, which initially varied from packing a bag and running away in the middle of the night to giving up the baby for adoption. These thoughts made complete sense to me at the time. I had a detailed rationale for why they were accurate. I had no understanding that these thoughts were distorted and were twisted. Over time, the thoughts morphed into images of driving my car off the edge of the mountain on my way home from work, or jumping off our cabin's third-floor balcony. As the images whirled in my mind, I would clench my teeth and try to force them away. It was very, very dark. I didn't want him. I didn't want my life. I believed that these things were real and true and certain. I believed these were my thoughts. Part of me deep inside knew something was wrong, but I was powerless to act. I remember briefly mentioning to my husband, Brian, about having a dream where I jumped off the balcony, but then I quickly minimized it. I filled out the Edinburgh Depression Scale in the OBGYN's office, careful not to endorse any symptoms that would get me hospitalized. We use the term a cry for help and generally refer to a person being gamey or not truly serious about their thoughts and intents. And I can see how it looks that way. But I now know without any doubt what a cry for help really is. It was the weak, thready voice of the last piece of me left in my mind, the last flicker of light not darkened by postpartum depression. It was the last bit of me that was not pinned down under the weight of illness. Those weak cries for help were the best I was capable of. The illness was just too great. My mind did not belong to me. My thoughts did not belong to me. I just didn't realize it. I was able to work. I was able to function. I had no idea the severity of the illness gradually taking over my brain. Over the years, I've treated many patients who've gone to the brink of death by suicide and yet were brought back. A number of these patients have been physicians who had previously made statements in their lives such as, "I could never commit suicide because," or "I've had too much to live for." When I think about 400 physicians who commit suicide every year, I doubt any of them were using normal reasoning or ration at the time they ended their lives. For most, the onset of insight was insidious, and when symptoms of suicidal thoughts appeared, they believed them to be their own despite never having thoughts like that in their lives. The thoughts fit into a larger, distorted narrative that made sense with the context. In the same way, we do not blame those who succumb to cancer. We cannot blame those who succumb to suicide after battling severe depression. A person's ability to resist these thoughts is directly related to the amount of normal functioning left in an otherwise diseased organ. So where do we go from here? Postpartum depression affects the lives of over 500,000 women every year. It destroys families and severs the connection between a mother and a child. It is a deadly disease which cannot be combated through willpower. Every day, my colleagues and I are on the front lines battling this illness, which is insidious in its presentation. I believe we need to better prioritize educating and screening our postpartum patients. I know time is at a premium and I don't begin to have all the answers. What I can say is that the culture surrounding mental illness must change. Mental illness cannot be managed by willpower alone. Without a doubt, I know that holding it together is no way to live, work, or raise a child. 11 months after my son was born, I was treated for postpartum depression. I literally have over 3,200 baby pictures for that first 11 months, yet I have minimal memory of taking any of them. I can see myself lost in a fog, completely separate from the joy that's usually present in my everyday life. I lost 11 months to postpartum depression. As I began to heal, I remember looking down at his beautiful face, there in the darkness, and I whispered to him, "I would choose you." It was like it was the first time I had ever seen him. I have firsthand knowledge of what it looks like to be overcome with an illness of the brain, of the mind. This is not metaphysical. Sharing all of this is so important. It is chemical, it is biologic, it is illness, and it is the most terrifying I can imagine, and help exists. This is overwhelming for me in some ways, and yet it's seriously about life and death. And if hearing my story helps to better help you understand what 1 in 7 of your postpartum patients is experiencing, then it's worth it to me. Thank you for your time and for your interest. Please contact me if you have any questions or want to discuss the presentation further. I appreciate your time.
Wow. Thank you so much, Dr. Pereau, for sharing with us this medical information, but even more so for sharing your powerful story and your commitment, passion to help others with this condition. So great presentation. We've gotten several responses in the Q&A commending you for your job. Yeah, when you set off my amygdala when you were giving that hopefully fictional example of your partner asking you to cover before your vacation 4 days from now. So my amygdala is back down into working order for the time being. So we'll get into some questions here. First question is, do you know if excuse me, do you know if there's a difference in the prevalence of postpartum depression across different cultures, say non-Western cultures versus Western cultures? Do you know if anybody's looked into that at all?
It's certainly something where there's a lot of research looking at prevalence of depression within different cultures, and certainly within the United States, there's been recent data looking at healthcare disparities and patients who are from minority groups and their lack of follow-up for postpartum depression, their lack of access to care for it, and a lot of that being not necessarily the access is not there as much as a concern, a fear, and unwillingness because of racial issues where they would be judged differently than anyone else with postpartum depression. And those studies are coming out more as we're looking at the populations within our own country. But I certainly have seen studies that are looking at postpartum depression and even the type of presentation that differs culturally. And there are some really interesting papers looking at depression in Egypt versus depression in China, and how do you do screening, because the screening that we use may not be applicable at all in other cultures. So there is definitely things coming out. I don't have any numbers, but I think it's really interesting to go look and see what's out there.
Yeah, I mean, it is a great question. I could imagine be a very difficult study because of the differences in reporting and the cultural influences. So our next question, a comment and a question. Great presentation. Thanks for affirming that the science behind the clinical blackness of postpartum depression is very real. It helps us primary care docs appropriately educate our patients in the postpartum time frame that this is real, and that clinical changes can be understood and treated. So again, a comment of appreciation. And in that same vein, being such a prevalent condition, 80% postpartum blues, and somewhere between 10 to 20%, prevalence of postpartum depression is significant. And linking that together with, I liked your quote, this is a brain that is not functioning normally, and no amount of willpower can just take this away. And on top of that, the lag between patient reporting, even in your own personal story, the lag between patient reporting and also the length of time for the effect of treatment. So before the effect of the medication comes on. So with those things in mind, any thoughts or recommendations about how we can better prepare for such a prevalent condition? Are there some sort of preemptive treatments we need to be thinking about? Do we need to change our recommendations about follow-up schedules postpartum? What are your thoughts about those things?
We know that a prior history of depression, bipolar disorder, that those increase the risk. And certainly having postpartum depression in the first pregnancy increases the risk for the next pregnancy. So my thought is a couple, but when it comes to depression, anxiety, patients that have had a known history and have had treatment for this, it would make good sense during the pregnancy and the postpartum to have them have psychiatric follow-up, the same way that you would identify a patient that would be high risk in other ways medically. And so I think especially those patients who've ever had a suicide attempt, those who have ever been on medications, those who've ever had psychiatric hospitalization, and that's not a whole, psychologic history that you have to do. It's asking a few things about suicide, hospitalization, prior medicines. And if a patient met those criteria, then asking more questions. So I think that we know that there's patients that are higher risk, and identifying those at the beginning or in the middle of the pregnancy, I think is very important. When it comes to getting better help, getting better assistance for these types of patients, my thought process and what Dr. Hart and I were looking at with the clinical question of, can you use the educational period during the third trimester rather than trying to do this while the person's in the hospital? From my own personal experience, I remember I'm getting ready to leave the hospital. They're showing me how to put the baby into a car seat, which is the most foreign thing on the planet. Another person has come in and showed me what to do with lactation. And there's a million things going on. And there was a nurse that was kind enough to say, "You feel just fine right now?" I said, "Yeah, this is great. I got this new baby." And she said, "Keep an eye on it for the next day or two." And I remember like a crash had occurred. And I was very grateful that that woman took 2 seconds to explain this. But when it comes to postpartum depression, I think that additional information for the families is the most important. If I have one thing that I could do differently, would be somebody telling my husband, "Hey, if you're seeing this, this, and this in your wife at 2 months, 3 months, 6 months, get some help, because this is not what this is supposed to look like." If you see a person that's disengaged, a person that's not engaged with their child, somebody that is struggling with crying episodes, somebody that continues to struggle with just doing basic things around the house, this is not supposed to be there at 3 months, 5 months. And this is more than just we're overwhelmed because there's a new baby. There's distorted thoughts, there's negativity, there's fear, and there's a lack of connection to the child. And those things are not supposed to be there. And I think better education of families, potentially even in that third trimester, when you have a family member present with you for your ultrasound or for your checkup, just even pulling them aside or handing them a pamphlet or going through and say, "Hey guys, this is something that you're going to be able to help as part of this team."
Yeah, very, very excellent response. Question came in about the incidence of postpartum depression in patients who have seasonal affective disorder. Any thoughts on that?
That's a great question. I don't know about incidents with seasonal affective disorder, although I would assume that those with a history of seasonal affective disorder will then be at higher risk of depression during the season that they've had in the past. So they may deliver their baby in the summer and then end up with postpartum depression that doesn't manifest till later in the year. And that would definitely be something, again, worth screening and watching for.
Right. And then one final question, you in the slide that you showed about treatment, in the mild symptoms category, you had recommended medical leave off work for the mild category. I know that some of the occupational medicine studies, promote like return to work as soon as possible and so forth. That's always a challenge. I think as a primary care physician, that's always a challenge for me. Do I take this person off work? Is that going to harm them? Is it more beneficial to keep them at work? What are your thoughts on that?
That's a great question. I do think that oftentimes for patients that have mild symptoms, being at work, being engaged with others, having their normal structure and routine can be very healthy. And so really when you're looking at postpartum depression, a lot of it has to do with what is this person's functionality. And if they are getting their ADLs done, but just barely, and they need help with the child, or if they're showering, but it's only twice a week, you might not necessarily need an SSRI, but if it's taking all of their energy and all of their ability to shower 2 times a week, they're probably not ready to return to the floor doing their shift as a nurse. And so I think a lot of it looks at functionality, and you can have mild depression and not necessarily need an SSRI, but you've got a person that needs more sleep, that needs more support. And a lot of these cases that are really more mild depression, when you're talking about problems with energy, motivation, but they're bonded to the child, they're not having thoughts about suicide, you can be able to improve their sleep, improve their support in the home, improve how much they're eating, and you can see that perk up within a few weeks, and then they're ready to get back to work. And so for me personally, I think looking at functionality is very important.
Thank you again, Dr. Pereau, for this presentation and for sharing with us your powerful story. And we wish you the best of luck in terms of your moving forward and helping people with postpartum depression. Again, thank you for your contribution.
Thank you so much.